Good afternoon from Boston, Cambridge. My name is Dr. Umbereen Nehal. Really a pleasure to be here. So a bit about me. So I've been building health. I actually did not realize I'd been building health tech for 20 years until I had to justify being allowed to sit for the informatics boards. And I was like, yes, I have. I focus on ethical AI, patient e-community. I was co-author of Medicaid restructuring in Massachusetts and something called the State Highway to allow interoperability for the US where we don't have a national healthcare system, there's a lot of like falling between the cracks between different vendors and things not kind of connecting. So even within Boston Children's, a place that has tons of specialists, there's a lot of times like lack of connection across silos within the same hospital. So we had optimized how communication happened within the hospital. I'll skip over a couple of the rest of this just in the interest of time. So let me just move this so you can see. So there's tech. So there's a difference between lifespan and health span. So women live longer in terms of the number of years, but women also spend 25% more time in poor health. So a lot of times, when we have these like so-called gender wars, men are like, well, you live longer. And it's like, well, we would also like to thrive, not just survive. I mean, we all should, regardless of gender. So the impact economically, according to the World Economic Forum and a McKinsey report, is a loss of $1 trillion, the cost of women's poor health, as well as health gaps globally. Drilled down to menopause specifically, that's $4,600 per woman per year in the US context. So that's a lot of money. This is personal. So misdiagnosis and late treatment, despite the fact that I'm a former chief medical officer of a $100 million operation, used to get invited to the White House. That's me with my little MIT bag, getting the first of 6 blood transfusions for very, very common conditions like fibroids, endometriosis. There is absolutely no reason I should have needed even the first blood transfusion, let alone 6. And I've been blessed with a number of common conditions like, my ovaries were, not functioning so well earlier, perhaps due to the endometriosis I have. So we in science tend to look at things through molecules. Like as a physician, I learned the Krebs cycle. I learned, various pathways. But life is messy. We human beings live in multiple domains. And so the way we look at things through science often misses the lived reality. And so that's what this talk is about, is how can we be human-centered? How can we start with the human being and then work backwards to science or connect to the amazing science that's happening on a molecular level, but sometimes kind of misses it in terms of getting implemented. And personally, at MIT, I've done work on systems thinking. My career has generally been on systems design. And next year, there will be a book coming out on systems thinking for physician leaders with the Association for Physician Leadership. So it's really about thinking about systems. So this is a busy slide, but there are challenges in clinical trials. Women's health receives only 1% of research dollars in the US. Conventional approaches are fragile, even before we were in the current state where there's a lot of cuts to funding. And then recruiting women is hard. Women do a lot of caregiving. Women have jobs that don't always allow you to get a flexible time off. So even when you enroll women in clinical trials, keeping them for completion in a successful clinical trial is difficult. So where do we get these data? But even for, again, thinking about a system, so there is the science part in the clinical trials. How do we generate the evidence? But then how do we implement it, right? So for women are experiencing lack of personalized data-driven navigation. And every vendor in the US is selling doctors something, but we're overwhelmed with every quote solution, which often sadly wastes more of our time with additional logins and et cetera. So as a result, at a system level, women are unsure when it's bad enough to seek care, don't get personalized, data-driven, or culturally appropriate whole person care, and there are delays and gaps. I left this slide in on purpose. This is not supposed to be red squares over, blocking things. And this is exactly what we're dealing with. We're dealing with lack of interoperability. I made these slides initially on PowerPoint, then did some stuff on Canva, then brought it back to PowerPoint. And now the key thing that I wanted you to see is blocked. This is happening every day as patients try to navigate care, as well as doctors try to coordinate care. But the point here actually is shared decision making. On the patient side, patients want to be informed, engaged, empowered, partnered with, and supported through an e-community. This is the broader system. So the real slide is this. The magic happens, outcomes happen with informed, activated patients and interfacing with a prepared, proactive care team. So how do we achieve that? So our value proposition is AI-guided navigation across trusted educational content, care pathways, pre-visit preparation, and translating user priorities, strategy values first, and priorities into personalized learning and next steps. How we're differentiated is we use clinician-approved sources, behavioral grounding, and decision support for both the woman and the care team. So a lot of clinical decision support is focused on the doctor, driven by the payer or insurance about, okay, these are the things we pay for. This is the evidence-based guidelines. What kind of evidence if women's health is not included in the evidence, right? So how do we do this better? And apologies, this is, okay, so a scientific basis. So we're using clinical informatics, behavioral science. So we're doing a couple of things. We're taking what women are saying in journey mapping using social media data. And then we're also evaluating custom AI agents that personalize education and navigation on conditions, nutrition, non-pharmacologic lifestyle options, and selecting the right clinician. So we are not going to help you diagnose. We're not going to help you say, okay, this is the right treatment, because the tech is not there yet. That would not be responsible AI. But a lot of times being heard for heard is matching to the right clinician or knowing ahead of time what are the treatment options available with that clinician. So very, personal note, I was, many women, 70 to 80% of women have fibroids. I had fibroids. I did not know that besides hysterectomy or fibroidectomy, there's uterine fibroid embolism. You have to go to the right clinician to even hear about that option. So that's where we come in, get you to the right clinician so you can have the right conversation. And there's something called PRO or PROM, patient-reported outcome measures. Why are we focused on this? So their payment is moving towards these research grade data of quality of life measures. So traditionally we've looked at, has your hemoglobin A1C moved? Has, this changed? This is actually saying, are you able to brush your hair? Are you able to do your chores? Are you able to engage in life? So this is a patient experience of the outcomes of treatment or of having an illness. And so this is an example where, we can take this really dry, usually used in clinical trials or research and make it much more accessible to the patient. You can, start with what do you want to talk about? What's bothering you most? And then give that part of the questionnaire first, right? You can vary the language and then you can get this questionnaire filled out, but in a way that's much more accessible. And then the other part is using voices as data. So there's voices in terms of there's amazing, really cool tech about using like recording of your voice to detect like Alzheimer's or dementia. But we're actually, doing harness, empower, and redesign her in a different way. So actually pausing, if you were an investor and you saw something was growing 37% year upon year, would you be interested in investing? Would that get your interest? I mean, I would like that kind of return on investment, right? I'd love that kind of growth. So what does this number represent? It's actually Reddit is growing at that rate. And so Reddit is this amazing living data set that can be used for patient journey and influencer trends. Like what are people talking about? What are they experiencing? It's used for social listening and pharma and biotech. You can use it for disease surveillance insights. So if there's a ton of research that's been done like during COVID or, now as in the US, we seem to want to kind of let things rip a bit in terms of diseases. So we're going to have some interesting data to follow on Reddit and social media in the coming years as vaccine policy changes. We can look at belief and mistrust. So one of the things that we're doing is we're training a agent that can go through a community and identify levels of medical mistrust. So personally, I have one foot in the science world. I feel very comfortable in the US and Europe, but I have one foot in Pakistan, in Muslim countries, in communities of color. I'm very well aware that many communities science in certain times has been misused to harm communities and to extract or surveil in ways that are not like good disease surveillance, but negative things. So I don't want to shush anybody or silence anybody, but nor do I want to be a source of misinformation. So one thing we can do is we can using existing data, we can train an agent that goes through a community and says, this is green, yellow, or red in terms of level of mistrust. You can choose then what kind of community you enter into, and we don't have to have one size fits all. Her herd, like elephant herds, they're multiple herds. You can choose your herd. And then making sure that we can accommodate different beliefs and mistrust while also flagging what is scientific or not scientific according to our current understanding of science. And then further, it's Reddit and other social media platforms are really great for clinical trial recruitment and reaching out to the community. So this is an example of we identify the most engaged subreddit posts on fibroids. And you can see, right? So one here, people do not stay within a silo, thought it was fibroids with cervical cancer. Pretty important. If your AI is not thinking about that, is just trained in a silo, you're going to miss this. Getting some, emotional support, massive fibroids, a little bit of some political language in here too, but this is real. This is what patients are talking about, and this is not getting discovered in the clinic. So this is an opportunity to really meet people where they are. So just pausing here because it's a bit busy. So where can agentic AI work? Not merely as as a pre-visit assistant, but as an orchestrator. So you could have not just a chatbot, but an adaptive orchestrator that can help kind of, say like, okay, this is where the responses are going. Let's move in this direction. It can reduce patient fatigue and administrative burden, harking back to that slide I showed you, where instead of like a dry questionnaire, it can interact with you and it can prioritize the questions that matter to you most. So that way you stay engaged and interested. It can also, with natural language processing, NLP, you can structure free kind of narrative describing what you're feeling and bring it into pros and prompts. There can be prompts for shared decision making for first value. So a lot of times people are very focused on like, I need to get this. I need to get this medication. First, you need to know, what are your goals? What are the things you care about? What are the values that drive the life you want to live? And then centering on that, then you can discuss the specific options rather than going right into a fight over sort of like, oh, I want this med, no, this med, let's not even start there. Let's start with, what do you want? What do you value? What are your goals? Now let's consider together, what are the solutions that we can consider that might get you to that goal. There's one of the things is that some people are trying to create this like, a bit sacrilegious, but like God model that's like all knowing. At MIT, there's actually some research that shows rather than having one all knowing LLM, have multiple LLMs that debate each other. Or, if, for instance, if you're a patient, you might want to get a second opinion. You could also create LLMs that have like, large language models, chatbots, agents represents like, okay, I'm the gynecologist. This is what I would offer for a hysterectomy. I'm the interventional radiologist. This is what I would offer. And so not the customized, not the like the diagnosis and treatment, but just sort of like, if you came to me, these are the options you would be able to have. So those are ways in which you can help people navigate and get to the right place more easily. You can, have searches that are aligned with preferences, and then, as we mentioned, clinical trials. So our solution harnesses voices, both in terms of journaling as well as what I showed you for it's for capturing data. So allowing women to be themselves and not constraining them that you can only communicate this way, but then allowing how you communicate to be brought into what scientists can recognize and what insurance can recognize. Empower with AI in the ways already discussed. And then we can redesign pathways so that rather than a one size fits all through a typical kind of insurance, like this is the right way, allowing more flexibility, allowing a more adaptive process. The opportunity is vast in terms of the longevity payoff, in terms of the quality of life, in terms of GDP unlocked, whether it's earlier detection of cardiovascular disease, dementia, maternal risk. So in the US in particular, we don't have a national healthcare system. So a lot of young women, if they're not pregnant, may be uninsured. And so that leads to very poor pre-pregnancy health, which then leads to more complications in pregnancy and worse birth outcome. By training, I'm a pediatrician. I'm board certified in both pediatrics and clinical informatics. So I think a lot about, these population health factors that show up in these ways, like at birth, and then what does that mean for the lifespan? And then for a health span, we have, can have fewer years in pain, fatigue, disability. So a lot of times insurance is thinking about sort of like, was there an amputation? Was there a hospitalization? But from a societal perspective, you need to think about, is somebody having so much pain or so much mental health burden that they're, suboptimal in terms of their ability to work, their ability to engage with their family, their ability to exercise. So that may not show up at the kind of the spike that is noticed by insurance companies or, even perhaps like government regulators, but does matter and does affect our GDP. And then, of course, the space in between. Actually, I went through this really fast, so we will have a lot. So this is actually, if you scan this, this is to our community. It's for women who want to join the community. But I was intending to be less than 40 minutes, but I did it in about, I think a little over 20 minutes. But I'm really happy to take questions because I really think it's really about being more interactive and connecting the dots.
Thank you so much, Dr. Nehal. We have one question in the chat about decision aids. So are patient decision aids part of the process?
Absolutely. So thank you for that question. Yes, so that is so what for her heard what we're doing. So I'll answer it in two ways. Generally, in terms of just the field, as well as specifically what we're doing. So yes, decision aids are really important, and the question is sort of like, where do you introduce them into the process? How does the patient get a hold of it, right? So oftentimes, though it's interesting, like we just launched this community, and initially the kind of the tech that we purchased, so it's like rented land right now before we actually build our own, had a lot of like, it was just like, what's your Twitter profile? What's your this? And it's like friends of mine that I asked just to beta test it were just like too complicated, feels like the doctor's office. I can't do it right now. And I was like, you can skip the fields, but women often are socialized to follow the rules. So even though I gave them permission to skip fields and not do it, they just couldn't. They're like, I'll come back to it, right? Oh, no, I want to do it right. I'm like, this is right, right? So the question is, in a world where, the average woman in her 30s to 40s is navigating a whole bunch of stuff, whether she works outside the home or not, she may be handling children that are her own, or maybe helping out with somebody else's, maybe aging parents. There's a whole bunch of stuff. So she feels overwhelmed. So yes, decision aids are important, and there are multiple types of decision aids. So there are like condition specific decision aids, like how severe is your endometriosis? How severe is your lupus or this? There's a variety of condition-specific decision aids. There are also so these are actually not even decision aids. This is one step before. This is quality of life measures. So you have to understand what are you dealing with, quantify it, prioritize it, and then you can have decision aids. Then for instance, I used to co-chair an advisory panel for PCORI, Patient-Centered Outcomes Research Institute. They do create a lot of decision aids, like for instance, for fibroids. There is one to say, like, okay, which type of procedure would you prefer? Where the rubber meets the road is how do you get that into the patient's hands? How do you get it into the patient's kind of attention span? And how do you get it into clinical work streams? So I have had three pelvic surgeries between my endometriosis and fibroids. I even was a PCORI panel co-chair, and stumbled upon it. And this is no ding on PCORI. I think PCORI is doing an amazing job. But that's just the challenge, right? So decision aids are important, whether it's assessing how severe it is, assessing your options, what are your values, what are your options, what do you want to do? But the more critical thing is how do you get it into the patient's hands? How do you get it into and the doctor's hands? And how do you get that interface? So it's not the patient coming when the doctor's like hassled by insurance, or the doctor forcing it on the patient when the patient's like, my elderly mom just fell. I can't, right? That's really the where we really have to figure out how to get this done.
Thank you. I invite you to raise your hands to ask any questions you may have, or you can put them in the chat, but preferably on the screen. While our audience is thinking, Nihal, I have another question for you.
Mhm.
Um, how do you get traction? So you came up
Yeah.
with this excellent idea, and in the overwhelming information pool that we're in now, how do you
Hmm.
even get noticed, heard, followed?
Such a great question. So, we've been, there are definitely some startups that launched a lot sooner than I did in terms of getting into the clinic. Personally, as a former chief medical officer, somebody who personally actually also experienced, so quick personal anecdote before I answer that question is that I was undergoing egg freezing like many women when I was in my 30s, just because somebody up there just really enjoys writing my life story in a way that is very, very interesting. I was assigned to restructure as the clinician with a larger team, restructure all of Massachusetts Medicaid. 1.6 million lives, right? 40% of the state budget. I'm going to get to the question in a second, but this story is relevant. I'm in the middle of doing that. I'm pumping myself full of hormones. So if anybody thought I was a little bit crazy, I would agree because nobody's supposed to have that many hormones on board. And then there was this thing on my ovary, probably fine, but could be cancer. Anybody who knows ovarian cancer knows that if you get diagnosed with it, you could be dead in 3 months. I'm sorry, that could be a little jarring for people, but it's a reality that people are dealing with, right? And so that thing on my ovary grew. I got rushed to surgery. And because it could cause torsion, whatever, just my luck. The day that I was scheduled for surgery, the Harvard hospital where I was having surgery, no shade on them, nothing wrong with them, just a process issue, had an EHR upgrade. Everything was on paper. I overheard the nurse, who was excellent. I loved her. She got my IV very quickly. She was so compassionate. She was a wonderful person. I overhear her saying, "Do I give this medication or does the resident?" Because the process was disrupted. Despite articulating that in the pressure to be efficient, she was trying to be virtuous. She goes ahead and almost administers it to me, which is a narrow therapeutic index, right? And they were double dosing me because I'm a doctor, so so some people get undertreated, and when I don't say I'm a doctor, I get undertreated. The minute they find out I'm an MD, now I'm overtreated, right? So thank God the resident happened to be walking by at that moment and was like, "I've already given that med," but they came inches. And I mean, look, it's a Harvard hospital. You can overdose me, stop my heart, and you can bring me back. I totally have faith in my colleagues, but like, try not to do that in the first place, right? So, how do you get traction? So, personally, given, and so that was the like I'm Muslim, so like that's the Bismillah. That's like the beginning of my like working on this massive reform. And I'm like, oh my God, if I change, if I restructure, like how many people are going to fall between the cracks? I was so stressed out that year. And so for me personally, I have wanted to, I'm a physician first do no harm. So there are some people, for instance, I know a really amazing startup that was able to go to they're not physicians, go to a physician conference. They had a physician sponsor, talk to a bunch of people, get into the clinic right away, right? And you could just sort of like, until you go and try things, maybe you have the guardrails in place and you try, you identify the error, you try again, you iterate. That's one way, right? So you get traction by saying, is there a pain point? Who's the customer from the clinician standpoint? How do I get into that clinic? Who's my first adopter, my kind of sponsor? And then how do I then expand into the market? That's one way. We have, I mean, just this week there was a article that came out about showing that when it comes to LLMs not diagnosing, not treating, merely triaging, saying that should you go to the emergency department or should you not? Um, More than 50% of the times for conditions like diabetic ketoacidosis, which is really severe, it can cause death, it can cause disability, it can cause strokes, a whole bunch of stuff. More than 50% of the time, it was under triaging, meaning somebody should go to the emergency department and it was saying, just make an appointment in 6 weeks, you're good, right? So given that I'm seeing, and even just my personally, I use, ChatGPT, Claude, Gemini, I'm just like, I use them all. And I typically use multiple at the same time. And I, just like I described earlier, rather than have one perfect LLM, get them to compete with each other. So typically I'm putting the same prompt into two or three at the same time, and then I'm cross-referencing it and I'm saying, and I'm trying to get the best result. So I'm making them compete to give me the right answer. Plus, also, these LLMs are designed to look right, right? Because they're probabilistic models. They've ingested the universe of knowledge that they had access to. They have calculated the probability of this is related to that, this is close to that, and they're just always really guessing. They're not deterministic, they're probabilistic. And so as a result, it will look right, but it might be wrong. And I find it personally a lot of cognitive load, and I don't like what it does to me emotionally, be constantly like, is this right? And so I take that work off of myself and I'm like, you guys argue with each other and tell me what's right. And then it's sort of like having interns where you kind of have one supervising another, and then you're like, tell me what I need to worry about. Right. So for me personally, because I feel very strongly, I've personally experienced near miss, potentially fatal medical error. I just a whole bunch of different stuff. I know that my data are not in the research. I'm cautious. I will acknowledge. And so that's why we've done a lot of this social listening. That's why we've done a lot of this, but in the process. So we've done like when we built like over 30 versions of like the educational or navigation LLM. And every time we test it, we run surveys with women. Well, those women are now our early adopters, like, right? So those are all the women who have shown an interest. They're willing to work with us and take surveys. So they're also the women who can then be onboarded first. And so one of the times I got invited to the White House I got invited to the White House by President Obama as a thank you for my work on Obamacare for making people aware of the new insurance options, the Affordable Care Act. I had zero budget, I had zero staff, but I was able to run about a dozen events in 4 different states. And I was able to do that using very classic community organizing techniques. So I am part of multiple organizations. I'm part of the American Academy of Pediatrics, the American Association for Physician Leaders, ACHE, Islamic Medical Association of North America. So with the latter, there are a number of immigrant physicians who run refugee clinics on the weekends or run blood drives on the weekends. So whenever you want to get something done, you want to look at the person who's getting something done, right? And it doesn't have to be exactly what you're trying to get done, but they're a get SHIT done kind of person. So then you can take what you need to do, find a way that is relevant to them, find a common value, a common goal, and ask them to run something for you. And so, similarly, when you're trying to use more grassroots organizing community approaches to get things out, you need to find those community leaders, like the church, the church leader, and doesn't have to be the priest. It can be the person who organizes the potluck, right? So you find those ways. And, I know that a lot of times when it comes to government, we try to be non-denominational, we try to separate church and state. But I really just think community organizations, whether they are faith-based or the running group or whatever, are really the way to go. You've got to find that watering hole. You've got to find the people who feel that pain most intensely, the ones who are solution oriented and will partner with you.
Thank you. That's fascinating, very fascinating examples and excellent answers. Um, ex Basically explaining how to get people on board. So, but I guess my question is your current organization, like what
Yeah,
you're setting up, heard,
yeah.
how did you basically use all your contacts from the past to say, hey, that's my latest thing, join, and you already had such well-positioned presence that you already had your audience?
Hmm.
Or are you struggling for audience, or you have too much and you don't know how to, where are you right now? Like, or is it difficult
Yeah.
to attract people?
So I will, so some of it I will have to tell you in terms of like how this new community goes that we just launched this week. But yes, I mean, previously when we were initially trying to launch more of the kind of self-assessment, the decision support tools, I was able to get like 126 people to sign up in the first 24 hours and almost 500 in 3 months with zero ad spend. So that was good, but how do you get them to come back? Right. So the thing is that, like, why, when you are in the moment, so what I realized was that, like, okay, if as a woman with if you are a woman with a uterus or a person with a uterus, and you get told you need a hysterectomy, that becomes a hair on fire problem. You're like, oh my God. Right. And then you're like, oh my God, where can I find this information? Right. But if you're not in that hair on fire moment, eh, right? It's like priority number 20 or 120, right? So then we kind of pivoted towards like, let's focus on those who are needing surgery. And that's kind of how we first then went to. So initially it was my own personal network and just the multitude of ways I'm connected. If folks don't know, I have almost 250,000 followers on LinkedIn. Even on sites where I don't have a picture, I don't have a name, I don't know, just the comments that I make, somehow I develop followers. So
Congratulations. So we need to take a master class from you, Nihal. That's fine. Or we can just get you on LinkedIn.
Umbereen is
Brilliant.
fine. My first name is fine. Yeah. But no, actually, and I actually do coach on this. I've just was taking a class at Stanford Lead with Jeffrey Pfeffer, Professor Jeffrey Pfeffer, who teaches power and, personal brand networking. So I've honed my skills a bit further with him. And actually I will be like launching a course on this shortly. But so for me personally, yes. Initially, I got immediate like people, and the interesting thing is investors cared more about how many I got in 24 hours because they were like, that is a pent up need. You are touching on a pain point, right? And so, but then the question is, how do you become relevant to be something that people come back to, right? Uh, so I've thought about it different ways. So first it was like, okay, women that need information. Yes, they do. They rush to it. And it's just like, but do they come back? Right? How can you build fast enough for them to come back? Then it was like, okay, let's do the surgery thing, but then they are interested in what surgery, but then again, how do they come back? Right? Beyond that surgery. And so then with all the research we've done regarding what's working and not working on Reddit. And people from the beginning were like, you're so good, Umbreen, at creating community. build a community. And I was just like, I am not going to become the hotbed of like misinformation. I read this, that is the last thing I want to do. First, do no harm. I don't want that to happen, right? Nor do I want to silence anybody. So a couple of years ago, there was a case in the US of Dr. Susan Moore. She was an African American Black physician who had COVID, who was posting on social media and physician groups that, she was not being taken seriously. She very tragically actually did die of COVID. And it may have been because just COVID killed. I mean, it actually took my own mother, in fact. So, but after she passed, there was a press release to justify sort of the treatment of like what happened. And she was called intimidating to nurses because she was knowledgeable and with a social media voice. Let that sink in. You're intimidating because you're a doctor who's a patient at the moment with knowledge and a social media voice. Why is that intimidating? Right? And that incident really just, I'm going to be a little emotional, was just a few weeks before my mom passed, actually. And it really affected like how I navigated in the hospital. I'm like, will I be that doctor? Will I be seen as a threat? How do I protect my own mother? Sorry. And I'm okay with being emotional in public because I think we need to allow people to be human. But that's why her herd is built the way it's built. Because you can't just be like, listen to me, shout. No. You need to first of all, when you're in that in that escalated emotional state, and when you think about the brain, there's the pons, there's your like, the part of your brain that's just breathe, like you have things where you hold your breath because your brain is going to force you to breathe, right? So that's just unconscious. Then there's a limbic system, which protects you like when you're under threat. It helps us reproduce. It's and that's takes over in extreme stress. And then there's your cognition. If we force women because they're being, medical gaslighting, so to speak, of like not being heard, dismissed. I don't love the term medical gaslighting as both a patient and a doctor because if you've seen the movie Gaslight, it is a criminal who is deliberately messing with the reality of a woman to drive her crazy to steal from her. Me as a doctor, I like to think I'm not a criminal who's trying to steal from you. But if the data are missing in the research in the so-called evidence-based guidelines, right, I will unfortunately become like a gaslighter because I don't have the data. And it's not about me being a greedy doctor. Literally, if I prescribe a patient something that's not covered by insurance, the patient's going to end up with a bill, right? And in the United States, the number one cause of personal bankruptcy is unpaid medical bills. So it's not about the doctor. But the thing is, but there's a perception. So in the United States, again, it's different in different countries. In the US, more than 50%, almost like I think 70% of doctors are employed. Although I advocated for the Affordable Care Act, the Affordable Care Act banned physician ownership of hospitals. While I get my profession has not been perfect, I have a hard time believing that Wall Street is better at running hospitals than doctors, right? So I think it's complicated, but there's a lot going on. People still perceive that doctors have all this power. And so when I go online and I look at what's happening on Reddit, just like, oh, that doctor, and you're just kind of getting, you're like, okay, go get him, right? That's not going to lead to an effective conversation. You going and talking to everybody under the sun is not going to cause you to center your values. It's not going to cause you to be calm. It's not going to reduce your inflammation. It's not going to improve your mental health, right? So that's where, and then tying back to the earlier question. The earlier question was, decision aids. Absolutely. Yes, we need decision aids. But so, as a pediatrician, I always worked in emergency medicine. I never had an existing relationship. I am almost a half century old, so I look younger than I am. But so as a result, I've always like not necessarily looked like in an American context, the Norman Rockwell painting of the doctor, right? I'm not like the gray-haired, silver-haired dude. And the good thing is that women can relate to me, mothers can relate to me. The bad thing is that this does not necessarily confer authority, right? So I always taught my med students and trainees. I was like, your first job, when you walk in the room, just make sure the baby's not blue, in which case you do need to jump into action. Forget the niceties, do introduce yourself, but go take care of the baby. If the baby is not blue, if you have 2 minutes, focus on the caregiver. Ideally, the baby, who is a dependent, or the child, is going to go home with a caregiver. Your ability to affect the health of the child depends on the caregiver. So you've got to connect with the caregiver, right? So it does not matter whether you believe what they're saying or not, but you cannot dismiss them. You can't be like, oh. My line was always just like, we've survived for millennia because of mommy sense. What is your mommy sense telling you? That doesn't mean that I automatically agree with everything you're saying, but I want to at least hear your observation, right? So if you think about the analogy or the story of the blind man and the elephant, each blind man was correct, but only had a piece of it, right? And again, that's also what her does. It's like saying, okay, what is your lived experience as a woman? I went to medical school, even though I was born in the US, I went to medical school in Pakistan. When somebody who tells me that the gas starts in their big toe and winds around their leg and goes up to their head and gives them a headache, is that scientific? Probably not. Does that mean I should dismiss it completely? No, because in their lived experience, there is some nugget that I can pull out, right? And that's what AI, if it's designed well, and if we don't lead with hubris, but lead with humility and truly are scientists, right? Because scientists start with a null hypothesis. I don't know. There's no difference. Probably not true, right? And then you have to prove to me that there's a difference. You have to meet the standard, right? You have to pass whatever p-value you set, power calculation you do. And so you have to be this like both skeptic, both a skeptic and an optimist at the same time, right? But you have to just always be like, I don't believe you. Prove it to me. Show me, right? Long answer.
Thank you, Umbereen. We have 3 more questions. I'm very keen
Oh,
to
okay, sure.
get
Great. I'll make
to
them
get
shorter.
to Great. Thank you so much. So Piers, please go ahead.
Thanks, great talk. Just to sort of my question is a little bit of context. So,
Sure.
professionally, I build decision support tools, most of
Amazing.
them in oncology, and but I've also got kind of quite an interest in personally because I'm just a very complicated family health situation. I think I'm the only person in my family who can claim to be healthy, and I think there's 7 of us. And I just wonder, what I'm observing is a real difference of behaviours between sort of acute crises
Mm-hmm.
and chronic disease. So in cancer, where I mostly
Mm-hmm.
build my stuff, I know basically what I see in the decision support communities and the patient support communities is once patients have discovered that they're chronic, they become
Yeah.
expert. And then you get quite strong patient-specific communities built with,
Yes.
yeah. So thyroid's done a really good job in
Yeah.
Europe. Breast cancer
Yeah.
tends to do a really good job.
Yeah.
The big missing piece, actually,
Yeah.
everywhere in cancer is the most important decision is right at the beginning. Is it's which surgeon do you choose, and no one's
Which
ready for
surgeon?
it.
Yeah. Yeah. Yeah.
That's the one that's going to this acute phase. Now, in my family,
Yeah.
I just give you a sort of sense. I've got one suicidal child, which I'll come back to, is kind of interesting. One who's been hospitalized with long COVID. One is going through a congenital heart defect diagnostics pathway. I've got a
Wow.
father-in-law with early stage dementia and a father who's dying of a stroke. And what I think's been really interesting is how the family has approached that, especially my wife's, similar sort of research to me, but not in medicine. And where it's working, because clearly, if you're having to react to these things, we used to go to WebMD or Dr. Google, and now we're going to ChatGPT.
Yeah.
And I've been taking my wife's chats and then going to cross-check reference them with clinicians just for fun.
Yeah.
And my conclusion is as follows. For the kind of acute complex stuff, it's utterly crap, other than one really interesting area. Suicide.
Acute complex stuff. Okay.
Yeah.
Okay.
So it's complete random number generator.
Yeah.
Other than where the lawsuits have hit them, which is in suicide.
Yes.
Yeah? And in suicide, the advice we've been getting, both as how to handle it as a parent and for the child involved, has been incredibly good. I mean, close to best practice when I go back and check it. And I just wanted to share that as a sort of two questions really there buried in it.
Sure.
Do you see the same chronic versus acute decision behaviors in the broad areas of female health? So the more you are, not a patient with their hair on fire, as you put it, an acute decision.
Yeah.
Does it become a more repeatable, pathway-driven specialty process? And what is your experience about kind of the quality side of the? I think behaviors are going to take people towards things like ChatGPT. And are you seeing the same problem?
Yeah. No, it's
and are you
definitely
seeing the same kind of garbage in, garbage out, with minor exceptions type behaviors? So do you see the dichotomy of behaviors, and do you think?
Yeah, I mean, I think thank you first for sharing, and I'm so sorry that you're dealing with so much. But I think it's really brave to share all that and to be open, and I think we need more of that. And hopefully you have good supports. In terms of so I mean, anecdotally, essentially, I was sharing a lot of what you're describing, right? About the different categories of whether there's like an acute crisis where suddenly there's a lot of interest, but then do you have the emotional mental bandwidth to really kind of check in with yourself? Can you tap into your values? Do you know what your goals are? And then, yes, in terms of surgeon, like that's something I learned the hard way, that yes, picking the right surgeon is awfully important. And so, yes. And then I think this is something, so one, we definitely have to have an offline conversation, but we're still learning and exploring. I don't have the answers yet for your questions. This is something where I do wonder, right? Like for instance, whether it's oncology or rheumatology, a lot of times people develop a primary relationship with their specialist, and that's the person who knows them. And oftentimes that specialist is also the person who's doing their hemoglobin A1C and they're diabetic and whatever, probably not their pap smear, but everything else. And so where should this live? Right. But then particularly if you think about things like autoimmune, there's usually co-occurring things, which if it's all autoimmune, fine, the rheumatologist can handle it. But if it's not, so, blessed as I am with the multitude of different things, that for my endometriosis actually manifested primarily as migraines. Now, endometriosis is treated like a pelvic disease that is treated surgically, which I hope we're not doing lobotomies for migraines, right? I'm sorry, I have a little bit of whatever humor, but so I do think it's a good question, right? Because in so many diseases, especially in women's health, we don't have the data. We don't understand the full scope. And it's sort of like, and then you made the point about the lawsuit. Yes, unfortunately, right? I wish we lived in a world where people just do things for the right reason. But oftentimes people respond to consequences. And so where there's, I would hate for us to be like, okay, we're going to sue you on this and sue you on this. But so much of safety and regulation has been in response to something bad happening, right? So I answered like little bits and pieces. I don't think I actually gave you an answer to your question. But I think that I think you're bringing up really complex and important issues that deserve like probably a whole nother talk. Pierce, did that help you a little bit?
Yes, thank you.
But I think we should connect offline because I think that it's beyond, and I also want in the last 6 minutes want to make sure I can touch upon the other ones. But I think that the high level, I would say that yes, I agree with you that the acute versus the chronic and subacute are very different animals, so to speak, even though the same human might experience all of them. And again, going back to what I said earlier, sort of like, so, where in the workflow is this? How does the patient get it? How does the clinician get it? Where are they both in the right work and headspace to actually have that conversation effectively to actually drive care plans and outcomes? I don't have the answers, but I think that's a really critical question. Other questions?
Yeah, thank you, Umbereen. And just for your information, in 1 month, Piers will be here with his colleague talking
Oh,
at
perfect.
Consilium on a slightly different
Perfect.
subject, but you're very welcome to join. And yes, I do hope you'll connect offline. So two questions that we had in the chat, and I think they're quite important. So I'd like to get your answers, but if you could keep
Yeah,
your responses relatively brief, we'll finish on time. So one
sure.
question is from Eleanor Raymond, and she asks the following. So you spoke a little about giving uninsured women more access to health information early in life. How much
Yeah.
evidence do you have on the behaviors behind accessing the community and potential self-selection for those who tend to already seek out health information?
Great question. I think it depends on how much you're expecting them to pull versus you are bringing it to them, right? So if you are, so I have also experience in global health, and so there are populations that may not have literacy at all, right? May not have access, may even if they may not have access to roads or internet at all, and even if there are roads, they may not have permission to leave the house. There are well-established mechanisms and well-published, on how to reach hard-to-reach populations. A lot of it really does have to do with community partners and, working within trusted relationships. As far as those who are uninsured, so the couple of things I mentioned was previously trying to make people aware of new insurance options about a decade ago. And then currently, I don't know that I can, at this point, through what we're building right now, can address the insurance issue, but where there are additional supports available for those who are financially strained, there could be ways to connect them to that, or at least allowing women to know the impact of their health or health options on their financial health, and making sure that financial literacy and financial health is not a silo separate, but is part of whole woman health or whole person health.
Thank you. And the next, it's a comment, but I think we can turn it into a question.
Sure.
So it's from Joanna Trimble, and it goes the following. I'm concerned with the manipulation of data and information available for AI users and decisions. As well, human nature usually leaves decisions until the crisis is upon us, as you described. Then action is taken to get more information. So, how would you respond to this comment?
So, I mean, in public health and in global health, sometimes that every crisis is an opportunity, they say, right? So if you know that so again, follow behaviors. Sometimes those of us who are more introverted, who are more scientifically, we're like, okay, this is the right way and top down, and you should do the right thing, right? But we need to do it the opposite. We need to just basically, like, as a pediatrician, I've just my patients don't listen to me. I have to run around the room and chase them, right? And so we just have to, I think not that we should assume adults are not that we should be paternalistic, but I would just say the kind of approaches we have towards a toddler, we're just like, they're just going to do what they're going to do, right? Like, have that same attitude towards adults. And rather than be full of judgment, like, tisk, tisk, you're not doing whatever. We're messy, weird human beings. And so, like, but yes, to the comment, yes, there are certain behaviors but we know these behaviors. So let's understand the behaviors. Let's see the opportunity. So, for instance, again, the Affordable Care Act, when they needed to try to get young people. So, in order for risk to work, you can't just have the people motivated to get health insurance who are sick, while then young, healthy people don't engage because nobody can afford that system. Right. So one of the things they did is that where do you find young people? They go clubbing, and after they go clubbing, they go out to eat. So if you go to like Hardee's or Arby's or whatever it is at 3 a.m., you find young people. You sign them up. Right. So just bread and butter, used for decades, community organizing, public health mechanism, things that work. Just use that, right? And don't judge people. And I don't think that the question asker or comment maker was making, but I'm just encouraging, leave the judgment aside. And, let's just get SHIT done. Let's just get results, right?
That's a perfect sentence on which we can close today's talk. Thank you so much, Amber, and very fascinating set of experiences, really eye-opening and very illustrative. I think you brought up such important examples to make the point. So thank you for sharing that. Good luck with your work, and
Thank you.
we hope to see you back. And thank you for everyone's time. Thanks for joining, and we'll see you in 2 weeks. Bye bye.
Thank you. And thank you, everybody, for coming.